Thank you for maybe sparing your time to maybe talk to us. I appreciate your time. Before we go further, maybe you'll introduce yourself, maybe tell us your name before we get into the details.
Well, my name is James Kago. I'm a hemophilia patient. I was born in with hemophilia patient. As a hemophilia patient, that was in 1983, back in Nairobi, but I grew up in Murang'a County. So hemophilia is a hereditary X-linked condition that is passed from the mother to the sons, or to the mother to the daughter, because it is passed through the X chromosome. And so I've lived with it for the last 41 years. And we realized, or I was diagnosed, I had hemophilia when I was barely 1 year old. The symptoms that manifested before I was diagnosed were that I was bleeding from my gums when my teeth, I started teething, and my parents realized there was a problem. And then when I started crawling, I had a lot of bleeds from my knees and my joint areas, especially the wrist and the elbows. And so they realized there was a problem. And every time I could get hit, there was the swelling would last longer than normal. So they visited quite a number of clinics and dispensaries before they were actually referred to Kenyatta National Hospital, where the late Professor Edward Kasili was able to diagnose me to have a blood disorder or a bleeding disorder called hemophilia. So at the time when I was diagnosed, treatment for hemophilia was purely on blood replacement, and I had to get a lot of blood infusions that time. And so I lived, pretty much every time I had a bleed, either I had been cut or I had been hit, and so I had a swelling, which we call an internal bleeding. It meant I had to go to Kenyatta National Hospital and get infusions. During the early years, every time I had a vaccination or an injection, you are aware that at the time they used to normally, boil the needles, and you'd actually be injected at the back. And so at the time, every time I had an infusion done, my swelling would last a little longer, or the bleeding where the injection had gone through would bleed a little longer. So I had again to be taken to Kenyatta National Hospital for infusion. That time blood was also an issue. So you realize at the time you had to mobilize your own people to come and donate blood for you. Screening was an issue, and I must say I was lucky that at the time in the 80s and early 90s, uh, many of the other hemophilia patients who are actually relying on blood transfusion, some of them even contracted deadly diseases like HIV and AIDS, and some even got hepatitis B. But I was lucky, at least I didn't get any of those. In the early 1990s, as technology was improving, I stopped getting whole blood and I started getting fresh frozen plasma. Of course, it's a blood product, and we still had to mobilize people to come and donate whole blood. But that meant it was faster for me to be infused than when it was blood. Blood sometimes takes longer for you to be infused. As years again went on, technology improved, and I no longer now got fresh frozen plasma. I was now getting cryoprecipitate. In 2005, I got the first donation, or the first injection, with factor replacement, which we call the factor 8 concentrate. And you will not believe it, but the drug at the time was 3 years expired, but it did wonders. And what we later came to learn is that even though the drug may have expired on the date, we normally say it may have lost its potency, but it is not harmful. So at the time I was injected with the drug, and within 15 minutes of my injection, the bleeding that I had, the swelling that I had, started subsiding. And it was very clear that this was the technology that a lot of hemophilia patients were actually waiting for at the time. And so since 2005, I've been managing my bleeds using factor replacement or factor concentrates, and I can say now life is much easier. At the time when I was diagnosed, in my earlier years, I came to learn later that my doctor one of the doctors who were actually managing my condition after I was diagnosed actually had a candid conversation with my grandmother, who I was living with at the time. And she was informed, your son has a very serious congenital problem, condition, and rarely do hemophilia patients live to be above 18 years. And we, so for her, for her just to ensure that I lived a normal life, or at least I lived a little longer, it became a life of don't do this, don't do that, don't play with those ones, don't do this, because there was that fear of me being hit or being cut, and which meant then I would have to bleed longer. So for any hemophilia patient, it becomes a very cautious life. You have to live a very cautious life. Especially the parents are very cautious. They don't want you to play. And it's very scary even for parents that even when their kids go to school, any phone call from the school, even when they are not telling you about the child, is always a very scary moment, because you don't know what could have happened to your son. Yeah. So at the time, we actually also believed hemophilia was more about the boys than the girls. But as time goes by, we've realized that even the girls also bleed. And so we've been carrying out testing for girls. And you realize the girls have one X that has the hemophilia gene, and so they bleed. They may not bleed as heavily as us because they have the other X that complements the other one, because the clotting element is in the X chromosome. So for the girls, they don't bleed too much than us, or as much as the men. But then you realize their cycles could be slightly heavier than the normal girls. So we've been doing advocacy. I started from an early age. I started getting involved and getting to learn as much as I could about hemophilia, so that I could at least also avoid areas that could actually get me hurt. And so as I grew up, I learned so much about hemophilia. I knew about how to self-infuse, how to take care of myself, even without going to the hospital. And so um, I got involved also, in seeing how do we establish support groups where parents and patients can actually come and learn more about hemophilia. So that's how I got involved in the Kenya Hemophilia Association, where I'm a board member and current treasurer. I became active in the association when I was actually, in fact, I became the chairman when I was 23. And later on, of course, in the subsequent elections after that, I was elected as the treasurer, and then we got Dr. Kibet Peter Shikuku as the chairman. So it's been a journey of advocacy and awareness creation for parents to come out. At the time when I was diagnosed, I think we didn't know a lot of hemophilia patients. Back in 2014, we would call for a meeting for hemophilia patients that were being seen in Kenyatta National Hospital, and around 34 patients would come. We've done a lot of awareness creation through the support of partners like Novo Nordisk Hemophilia Foundation and WFH, World Federation of Hemophilia, who normally give us the factor concentrates. And so we have seen the patient numbers grow. In Kenya, we anticipate that 5,000, because hemophilia affects 1 in every 10,000, we anticipate we should have around 5,000 hemophilia patients. But to date, we've only been able to identify 1,044 patients, meaning around approximately 4,000 patients are still out there, not diagnosed and not receiving any form of care. So meaning that I believe they could be really, really struggling with how to manage hemophilia. And so we are trying to escalate our efforts in terms of awareness creation, and that's why we came to this conference, and we are part of the sponsors of this sickle cell disease and hemophilia conference, so that we can be able to create awareness about hemophilia and sickle cell and other bleeding disorders. So for us as Kenya Hemophilia Association, our main aim is to see majority of the patients who have hemophilia coming out to seek care, but also sensitizing our government on the need to improve care. Personally, I've been able to live with the condition. I have been able to pursue education. I've gone all the way to university. I'm currently working. And I have seen the power of education, but also the power, if you have quality products. I've seen how your quality of care your quality of life can actually improve. So my call to the government is, even as we work towards implementation of the shift, we need to find a way of incorporating these congenital conditions like sickle cell disease and hemophilia into the minimum package, so that at least we start packaging, or we start offering support to patients, especially with their treatment products and also with admissions. A lot of sickle cell patients and hemophilia, we have a lot of admissions in hospital because of the kind of and the nature of our condition. So it has not been an easy journey with living with hemophilia, but at least I can confirm that I was able to pass the 18 years that had been prescribed that time. I actually doubled it and added a few, and I've added a few more years to it. And I believe I'll live longer beyond, just to, as a testament that with proper care, any hemophilia patient can live a normal life. Thank you.
That is just wonderful. Daktari, you've worked with us since when you realized that you had this kind of disease up to the point where you are right now. It's a positive testimony that, this is not life and death. It is maybe taking care of yourselves and making sure that you be very keen as far as your life is concerned when you may be diagnosed with this kind of disease. You are talking on two perspectives. One perspective on the doctor side, being a doctor. Then the other side is being a patient of hemophilia. Now, on the side of being a doctor, how expensive is it to treat hemophilia?
So, well, let me first clarify that I'm not a medical doctor. I'm actually I've done HR or business administration and specialized in HR. But quality, the kind of costs that we talk about when it comes to management of hemophilia, a simple trauma to a hemophilia patient, say a child above, below 7 years, or actually even around 5 years. A simple trauma as just a small cut, we require an infusion of between 1 day to around 3-4 days. So, and each single infusion costs around 50,000 for that baby. So that means just to manage a simple bleed for a child with hemophilia would cost you up to a minimum of 300,000. For a person of my age, you realize I require on approximately 3,000 units, or what we call 3,000 international units of factor concentrate. And 1,500 international units today costs 50,000 in Kenya. So for me, a simple infusion would cost me around 300,000. Of course, technology has improved. I'm currently on prophylaxis of a product that we are currently getting from donation by the World Federation of Hemophilia, that I get an injection once a month as a prophylactic process. And that drug costs around 1 million shillings. We are 34 of us in that project, and we hope that many other patients can actually be enrolled in that. So what that injection does, it creates, or it boosts your factor level in the body, and it's able to last for almost up to a month in the body. So you find simple bleeds that were being occasioned earlier, say like gum bleeds, you are hit, simple traumas. Now I don't have to bleed longer because of that prophylaxis kind of treatment. But then you realize, when you look at the cost associated with it, very few can actually afford it. So our push has been, the WFH, or the World Federation of Hemophilia, has been donating these products to Kenya. The government has been generous enough to waive the taxes associated with the importation of the drugs. But then our push is, the Kenyan government may not purchase all the drugs required right now. But then we have to put a mechanism in place where we start buying, even if it's 10% of the drugs that are being donated, because you realize the donors at some point will get tired. But then we have to prepare for when the donors leave. What next? What happens to these lives of hemophilia patients? So the government needs to start committing resources towards purchasing factor concentrate, so that we build the capacity, you know, just to be able to offer care. In my life as a hemophilia patient, we used to advocate a lot about prophylaxis for children, especially under 10, because of they still don't know about their condition, and so they'll go out there and play football like any other child, and by the time they're coming into the house, they have a bleed, the knee is swollen, possibly there was a tackle in the field and the person has swollen. But then we have also realized, as you grow older, even normal people, as you grow older, your joints start paining and stuff like that. So you can imagine, for hemophilia patients, as they grow older, the joints damage also become more. So they have more joint problems than, when they were in the mid careers. So my push is that even as we talk about prophylaxis for the children, we also need to start thinking of how do we also introduce prophylaxis for the older generation. Of course, the ideal situation is everybody should be on a prophylaxis. But as we speak, it would be nice if we can at least segment the two extremes, the children and the older population also with hemophilia, so that they start getting this kind of prophylaxis. Yeah.
Thank you so much, Daktari. Daktari, if you look at, according to your statistics, it seems that there are a lot of hemophilia patients who are outside there. Maybe because of, they're afraid to come out and speak about it, that they have the disease. What could be your word to them?
So, you are aware that any congenital condition, and not just hemophilia or sickle cell, any form of disability in Africa is shunned away. There is a lot of stigma associated with
Exactly.
disabilities, and people perceive a person with disability could actually be, either you're bewitched or you're under a spell. And that's the myth we are trying to break, that, hemophilia and sickle cell are just like any other condition. It could be like asthma, but it's just that it affects me today. There are a lot of people who are suffering in silence, and also parents who their children have this condition, but they are still afraid to bring them out, either because of how they think the society will perceive them. My urge to them is there is treatment and care for both hemophilia and sickle cell patients. So bring them out, let's us diagnose them, and we introduce them to care, the appropriate care early in advance. So for example, for me, if I'm infused, I live a normal life. When I have a bleed, then it's a different story altogether. But for me, I have managed, and not just for me, we have educated I would say, all our patients on how to, before you get, for us, for hemophilia patients, we know, before you get a swelling, for example, you will feel some aura on the skin. You will feel like some irritation. It's not painful, but there is something funny you can feel. So at that particular point, if you are aware that there is factor concentrate and you go and infuse, and we have made sure that we have established treatment centers across the country. We have 16 so far, spread across the country. We are still doing more to see whether we can open up more satellite centers where factor is available. We do not charge for factor concentrates. It's purely donated factor to us, and we also donate it to the patients. So we don't charge. So what that means is that a patient can actually easily go to the treatment center, get infused, and they'll live a normal. That swelling will not happen. So with that, they're able to live a normal life. And so parents who have children who they think may have or may be portraying these bleeding symptoms, please bring them to any of our treatment centers. Let us diagnose them, and we'll be able to support them in terms of care, and as well as offer psychosocial support and training to them so that they can be able to live normal lives.
Okay.
Yeah.
Daktari, before we give maybe your parting shot, management of hemophilia, what does it take for you to manage hemophilia? Because as we've discussed earlier, that the society see those who are suffering from sickle cell disease and hemophilia not living beyond 18 years. What does it take for one to manage hemophilia?
So to manage hemophilia, unlike other conditions, hemophilia requires a multidisciplinary approach and team. So you find in hemophilia management, you require a doctor, say a hematologist who will be able to, look at the symptoms, refer you to the lab for diagnosis. The lab team must be trained in a special way because they need to do what we call coagulation profiling or coagulation tests so that they're able to figure out whether are you a hemophilic or you're not a hemophilic, and what type of hemophilia do you have, and what category. Is it hemophilia A, severe? Is it hemophilia A, mild or moderate? So based on that, they're able to see the factor levels that your body has. Then beyond the diagnosis, we require a nurse who will be able to take care of you on a daily basis. Whenever you have a bleed, you may not see a hematologist every day because they are also very rare. So you require another person who will be taking care of these constant bleeds, that is the nurse.
You are watching Media One International, always fast and fast. Like, share, and subscribe.